All right, good morning, everyone. We're going to get started. Welcome to Grand Rounds. We have a fantastic Grand Rounds today, which is updates in STIs, cases from the clinic and beyond. And we have two fantastic speakers who I always learn a ton from. Our first speaker is Dr. Stephanie Cohen. Dr. Stephanie Cohen is the director of the HIV and STI branch at the Department of Public Health and also an associate professor of medicine in our division. And followed by her will be Dr. Franco Chevalier. Dr. Franco Chevalier is the deputy medical director here at San Francisco City Clinic. We're really excited to learn from you both, and thank you for being here.
Thanks, Liz, for the introduction. Good morning, everybody. It's so great to be here in person. Franco and I have a bunch of cases to go through with you, so we're just going to go ahead and dive in. These are our disclosures. Okay, so we're going to warm up with, I'll say, an easier one. Okay, we'll see how you do though. So this first case is a 36-year-old man who comes into his primary care provider for an annual checkup. He's healthy, no past medical history. He's housed. He has a job working in construction. He doesn't report any substance use. He's sexually active with cisgender women and has had 2 partners in the last 6 months. And he had a negative HIV and Hep C test 3 years ago. So first question for you, what tests would you order today? And Liz, do we have the whole? I just advanced. Okay, so I'll read the options first. So would you get an HIV test, a Hep C test, a urine gonorrhea chlamydia test, a syphilis antibody with a reflex to RPR, or would you get HIV, Hep C, and syphilis, or would you get all of the above? So think about that one and you can vote. Love the live polling results. Does it tell me how many people have voted somewhere? No. Okay. Okay, it looks like we've settled out with the most popular vote here being for HIV, Hep C, and syphilis. And a few people just want to get, still changing some, just syphilis or all of the, oh, okay, I'm going to keep going. Thanks for registering your vote here. Okay, so I'm going to come back to the right answer in a minute. But first, just to remind everybody in the room that we have been experiencing for the last decade nationwide increases in syphilis among cisgender women and people who can become pregnant. And with that, we have also seen year upon year of rising rates of congenital syphilis. So the figure on the left shows this is national data from CDC from 2019 to 2023, with the number of syphilis cases in pregnant women in orange and the number of congenital syphilis cases in blue. And over this time period, we had a 104% increase in syphilis in pregnant patients and a 106% increase in the number of congenital syphilis cases. I will say that this trend seems to be starting to slow a little bit. When you look back at the period a few years before, the rate of rise was even faster, but this is still clearly unacceptable. Locally, we've been seeing the same phenomenon, although the trends here started a little later than they did throughout the rest of California and nationally. So here you see since 2014, the total female syphilis cases in San Francisco. The 2024 data are only through Q3, so don't get too reassured by that lower bar on the far right. And you know, in 2023, we had 202 female syphilis cases, and these patients have a lot of intersecting vulnerabilities. 21% were experiencing homelessness. And folks here at ZSFG and throughout our SFHN primary care clinics are diagnosing a significant amount of these cases, 47% diagnosed within those settings. And of our pregnant patients, the vulnerabilities are multiplied. Of our pregnant patients with syphilis in 2023, 9 reported meth use, 3 reported heroin use, and 17 had not had any prenatal care. So this is a top priority in STI prevention because congenital syphilis is a devastating outcome. It can result in stillbirth, neonatal death, blindness, deafness, developmental delays, and skeletal abnormalities. And as you all know, it is entirely preventable with diagnosis and treatment early enough in pregnancy. So this is a place where we should be able to make a difference. So in response to these trends, there's been a lot of thinking around, are we screening enough? Who are we not finding early? And in October 2024, CDPH released expanded syphilis screening guidelines. What's new in the guidelines is in green. So it used to be the recommendation was to screen all sexually active cisgender women. This is now all sexually active persons between the ages of 15 to 44, at least once in their lifetime. For example, our 36-year-old healthy cis man who has sex with cis women. In addition, when testing a person of any age for HIV, STIs, or Mpox, the third recommendation hasn't changed recently, but it's to test 3 times during pregnancy, at the confirmation of pregnancy or the first prenatal encounter, early in the 3rd trimester, and at delivery for all birthing patients. In addition, everyone entering a correctional facility between the ages of 15 to 44. And there's a strong focus on ER-based testing, again, because this patient population is so vulnerable and not connected to care. The ER ends up being the most common site of care for many of them. So we're really working to screen in those settings, particularly pregnant people in ERs and urgent cares who have not had a test for their current pregnancy. SFDPH has aligned with the CDPH guidelines, and we revised our citywide screening guidelines in January 2025. These are available on the City Clinic website. And again, just highlighting here the changes. Get a syphilis test in everyone at least once in their lifetime. And then, of course, more frequent screening for syphilis if there are additional risk factors, which I won't go through for the sake of time. We've been doing a lot of quality improvement work with SFGH to support syphilis screening within our network of care. For those of you who practice primary care here, there's a care gap in EPIC that is based on the logic I just showed you. So if someone is due for syphilis screening, they will have their care gap show up, and that's being revised to reflect these new universal guidelines regardless of gender and sexual orientation. In 2022, our internal medicine house staff took on an incentive project to increase screening among inpatients at SFGH, and Dr. Becky Brusca helped lead this effort and added an opt-out syphilis test to the admission order set, again, based on these screening logic. With that effort, there was an increase of 20.7% in the rate of syphilis screening for patients admitted to internal medicine at SFGH. So please help us out, screen your patients, promote the guidelines. And so for our case here, just to come back to the answer, I think the best answer here is actually number 4. He had had an HIV Hep C test 3 years ago, didn't have any other risk factors. Now you may decide you want to get an HIV Hep C. Maybe he asked for one. That would certainly be a reason to do it. But just thinking about the guidelines, what he is truly due for here is a syphilis test. So with that, I'm going to turn it over to Franco for case number 2.
All right, so case number 2. So this one is going to be a rather quick one, but it's essentially a 34-year-old individual who presented to City Clinic, HIV negative, who reported sex with women only, and at the time had just reported blisters as well as some itchiness over the perineum area, which, according to the patient, started 2 days prior to presentation. He basically denied any pain, and upon screening questions in terms of just sexual activities and behaviors, he really denied any sort of out of the usual behaviors for him. By that, I mean, he did not really engage with transactional sex, denied sex with men, denied any sort of other injected IV drug use and things like that. And he also denies a sexual activity for more than a year. And also, upon asking whether or not he had any STI testing, he said the last time that he recalls getting any sort of test, which to his knowledge, he does not recall any of which ones specifically he got, was about 50 months prior. And so on physical exam, we noticed this. And then this is a little bit closer of a picture, but essentially in essence, and I don't know if you can really appreciate necessarily in the picture, but it was this reddish appearing sort of nodules and macules that were soft to touch, quite moist and non-tender, all appearing around the perirectal region. And per the patient, he says he had not noticed that upon 2 days prior to that. And he doesn't recall any other symptoms. And then outside of that, there were other findings, but for the sake of this particular question, we're just going to leave it at that. And no, well, you have the answer. Never mind. So the leading clinical diagnosis here being condyloma lata. And this is obviously in conjunction with secondary syphilis, which was actually confirmed with a dark field microscopy, which was quite positive. There was tons of treponemes from one of the lesions, and he also had a positive STAT RPR. And his RPR was actually 1 to 32. You would probably expect it to be much higher, just given the fact that he had secondary syphilis. But the big thing here, or the big takeaway, is just a quick reminder of sort of the pathophys or progression of syphilis after exposure. And following along on this image, just a quick reminder that primary symptoms after exposure may take up to 3 to 4 weeks to actually manifest. And the primary development will be at the site of infection or inoculation, which usually presents with a primary chancre, as well as plus or minus regional lymphadenopathy. And then 2 to 6 weeks after, the patient progresses to secondary syphilis. So the chancre disappears. And worth noting is really the most important is the mechanism of or pathogenesis or mechanism of action of secondary syphilis, which is usually through hematogenous spread or lymphatic spread, which means that generally symptoms can be quite systemic. That's why you have a body rash. Sometimes you can have the palmar and plantar rash, as well as condyloma lata. So symptoms on secondary syphilis not often correlate with the site of infection, which is also something worth noting. And then once those symptoms disappear, and it's been less than 12 months, that's when you progress to early latent. And anytime you have no symptoms, in the absence of symptoms in greater than 12 months, that's when you progress to late latent. And then 5 to 25 years later, patients may then develop tertiary syphilis, although this is something that is quite rare nowadays, given obviously in the age of penicillin and the fact that we have such good treatment and testing now people more frequently. And so the teaching points or takeaways for this particular case, obviously we didn't get to do the question, but when in doubt, if there's ever a doubt as to what you're seeing, or you think that syphilis could be entertained, just trust your gut and pursue testing. You're never going to be wrong just for getting syphilis testing. And then if you have a high suspicion or there's any concern for loss of follow-up for these patients, just treating, just because it's going to do more good than harm in these settings, especially if patients have no known allergies to penicillin or doxycycline in this case too. And then secondary syphilis, just a reminder that it is due to hematogenous and lymphatic dissemination of spirochetes. So although the history may not often correlate with what you're seeing, just knowing that the symptoms can be quite systemic and doesn't necessarily has to fit the mold or the picture of the patient, of what the patient is saying. And lastly, if you're ever in doubt and you treat, substantial resolution can be seen 7 days post-treatment. So following up with the patients, just to kind of see and check how they're doing, you may actually notice that the rash is much better after that. And so with that, we have case number 3.
All right, thanks. We decided to just popcorn to keep everyone on their toes. So case 3. All right, so this is a 28-year-old HIV positive MSM who comes in with a painful lesion on his penis. He returned from Dubai 3 weeks ago where he had traveled for work. And 1 week ago, he visited Steamworks and had sex with one partner. He's on Biktarvy. His last viral load was undetectable. His T cells are 660. He has a history of syphilis. And his last RPR was 1 to 2, which is where it has been for some time. So we call that zero fast. He uses doxy-pep, and he has a history of genital herpes, but does not take suppressive therapy for herpes. So what would you do next? Okay, would you test for syphilis, herpes, and mpox and just hold off and await the results? Or would you test for all 3 of those things and empirically treat him? And if you do empirically treat him, would you treat him for syphilis, for herpes, for mpox, or for all 3, meaning test him and give him benzathine, acyclovir, and tecovirimat? Yes, thank you, Annie. So do you want to describe what you see, Annie?
It looks like really looks like an ulcer. I mean, it's round, but it's not like a typical blister or a vesicle. So it looks raised. I don't know if I'm being thrown by that. And it looks pretty discreet. So it's not falling into like an obvious category. That's definitely, yeah. Not a vesicle. It's not a vesicle.
Yeah.
But it looks like it's raised and umbilicated. So it gives me a little bit of an mpox feeling from
Yeah.
the 2022 days.
Great, thanks, Annie. I think that's a great description. So, you know, Annie's thinking through these 3. What about a chancre? Do you think Always could be. Okay, well, with that description of the lesion and these questions, let's see, it looks like folks have been able to go ahead and vote, which is good. And a lot of people want to treat for syphilis. Great. So you listen to Franco. Franco, they listen to you. That's great. Low threshold to empirically treat for syphilis when it's on your mind. And others are considering herpes, even though it doesn't really look like a vesicle, but of course, herpetic ulcers can kind of evolve, and there's only one, but that can happen too. So let's see what happened. So one thing you do is you call DPH and you say, I know it's not 2022, but I've seen this patient and it looks like what I heard Mpox looks like, discrete, raised, kind of umbilicated lesion on the genitals. So I don't know, I sort of worried, what do I do? And then you also get an RPR, which comes back 1 to 2, so stable. You get an HSV PCR that's negative, and you appropriately collect swabs for Mpox, and it comes back clade 2B positive. So wanted to just take this opportunity to give you a quick update on where things stand with the Mpox outbreak. In 2022, there was a global outbreak of clade 2B Mpox. This is the epi curve for cases in San Francisco from May 2022 to, this is data through October 2024. And you can see in 2022, we had a very intense outbreak, but since that outbreak, cases have been way fewer in number, sporadic, and continue to decrease over time. In 2022, we had 840 cases. In 2023, 93 cases. In 2024, 32 cases. And so far in 2025, we've had 2 cases, and this is in SF residents. So some of you may be like, these numbers don't quite add up, but this is San Francisco residents only. We discussed in this case whether you might empirically treat for Mpox with tecovirimat if you had high clinical suspicion. And during the 2022 outbreak, we did prescribe and dispense a lot of tecovirimat to patients. Unfortunately, we now have the results of a large randomized control trial, the STOMP study, which looked at tecovirimat for mild to moderate Mpox infection, thanks to Annie, who was the PI for our local STOMP study site. This was a 2-to-1 randomized blinded placebo-controlled study, and the results, which were presented at CROI, unfortunately showed that tecovirimat did not reduce time to clinical resolution of clade 2 Mpox, nor did it improve pain control in the studied populations. They also did additional sub-analyses controlling for symptom duration, number of lesions, HIV status, and prior smallpox vaccination, but that did not modify the results. There was a earlier study, the PALM study, conducted in the Democratic Republic of Congo, where most of the all of the patients really had clade 1 Mpox. That study also did not find a clinical benefit to tecovirimat monotherapy for Mpox. So that was, I think, disappointing. I think clinically, we all saw a lot of patients improve on tecovirimat. And I think really what that is a testament to is the fact that in most patients, this is a self-limited infection and people do improve. But we've also seen some very severe cases of Mpox, and across the country, there have been deaths. So when you have a patient with severe Mpox, especially if they are immunocompromised, the best course of action is not clear at this point, and definitely encourage you to consult. The thinking is perhaps combination therapies are the way to go. Brincidofovir with TPOXX, monoclonal antibodies, et cetera. So that is kind of where we are with treatment. I saw a hand pop up. No, we'll take questions a little later. Okay. So in addition, the clade 2B Mpox outbreak outside of Africa has waned, but there are still sporadic cases. Again, numbers low in San Francisco, but like LA has had more cases. So I don't want you to think this is over. And in addition, we now have a clade 1 Mpox that in August 2024, the WHO Director General declared a public health emergency of international concern. So that has now also arrived in the United States. And in November 2024, the first clade 1 mpox case was identified in California and in fact in neighboring San Mateo County. This was a traveler who had returned from Eastern Africa. He had a rash, definitely took a little bit of time for people to start thinking about mpox in him. But once it was diagnosed, he isolated at home. He recovered with just supportive clinical care. There were a lot of potential contacts that were identified. These were not sexual contacts. These were, they did a pretty expansive definition of close contact for this investigation. And there were no secondary infections identified. So at this point, there's not been any evidence of community transmission of clade 1 in the US, but we are looking out for it. And one of the reasons why there's even heightened concern with clade 1 compared to clade 2 is that it's thought that it may be more transmissible and that the clinical presentation may be more severe. The published data suggests that the mortality from clade 1 mpox is quite a bit higher, up to 10 times higher than clade 1, although I think we don't really know. The quality of those data are pretty limited. So what's the global picture? As of February 12th, there have been 3 more travel-associated cases in the United States. Again, no secondary transmissions. There have been cases in 14 countries outside of Africa, and a number of cases had, like our patient had recently been in Dubai, but a number of cases had reported travel to the UAE, and even before the UAE had reported any cases. So there is some concern that there's community transmission going on in that country. And we are monitoring for mpox clade 1 and clade 2 and wastewater surveillance, is sort of a leading edge thing in public health work. And there was actually a clade 1b detection in the Sacramento Regional Wastewater Treatment Plant on March 18th. When the San Mateo case occurred, there were also detections in the wastewater there, which is fascinating testament to how sensitive wastewater surveillance is. There have not been any cases identified in the Sacramento area. This plant apparently serves the airport, so there's some thinking maybe there was a traveler passing through. But anyway, all to say, these infections are out there. We are not doing a good job supporting or controlling the outbreaks where they are the most intense in Central and Eastern Africa. I read this morning that funding to Gavi, which supports global vaccines, is being cut. So this is there are many issues, a travesty right now, what's happening in public health. So keep a lookout for these cases and vaccinate your patients. So quickly wanted to review our vaccination criteria for Jynneos, which significantly reduces the risk of mpox infection, and in those who become infected, it reduces the severity of the clinical presentation. So I won't read all of these, but essentially the criteria are to vaccinate folks who are at risk based on a sexual orientation and gender identity. And now, because of the clade 1 outbreak, if you have someone who's traveling to an area where clade 1 is circulating and anticipate sexual activity there, please also vaccinate them. I will tell you, I continue to see patients every week who either never got their second dose of the vaccine or never got any of their vaccines. So you can give the second dose at any time. You don't need to restart, et cetera. And then lastly, we are asked consistently, what about boosters? Do our patients need boosters? We're now, 3 years out from the 2022 outbreak. There were a lot of posters at CROI that were looking at this question of how long does immunity last after vaccination and infection? And I just have a little screenshot here of a number of them. Most of them suggested that compared to people who had mpox infection, the detectable immune response, whether in T cell response or antibodies, wanes pretty quickly after vaccine. There was actually one poster, the last one here, which sort of suggested the opposite. So it's still a mixed picture. We don't really know the immunologic correlates of protection. And so based on the current state of the evidence, there is not a recommendation for a booster at this time. Locally, Franco is actually leading a research project to look at this question as well, working with Hyman and Scott and Tim Henrik. So we'll have, I think he'll be contributing to our knowledge base on this important question as well. Okay, so I'm going to popcorn it back to Franco for another case.
All right, so this case, bear with me, I'm going to walk you through this one just because it's a rather complex case. So this is the case of a 33-year-old MSM who was on PrEP and doxypep and was seen initially at an outside clinic prior to coming to City Clinic. So I think it's really important to sort of paint the picture of the complexity of everything that happened prior to coming to us, which sort of starts back in November 17th of 2024. At the time, the patient was reporting NGU type symptoms with dysuria and discharge, had some NAT testing at the time that revealed that he had Mycoplasma genitalium. He was treated with doxycycline for 7 days, followed by moxifloxacin 400 milligrams daily for 7 days. And he completed the treatment around the 30th of November, reported improvement of symptoms. Then December 12th presents for a test of cure, which many of us were wondering why, since it seemed to be too early. And at that time, it was positive, given that we know that there's a high chance of this test being positive if done at least less than 3 weeks after completion of treatment. On the 18th of December, yet again, he presents with recurrence of symptoms, and at the time reports dysuria and discharge once again. And the test of cure that was rightfully done once again shows that he's positive for Mycoplasma genitalium. For some reason, he did not receive a treatment at the time. However, on the 27th of December, he then presents again, and the urine NAT test reveals again that he's yet positive for Mycoplasma genitalium. And the patient decided that he wanted to self-pay to send for testing for macrolide resistance, which was sent to Quest and actually reported macrolide resistance. So based on this information, he returns to care on the 1st of January in 2025. And at the time, it's decided to start the patient on 7 days of doxycycline, 100 milligrams PO BID, followed by minocycline for 14 days daily. And then for some reason, he also got azithromycin, 1 gram times 1, followed by 500 milligrams for 3 days, and completed the full course of this on the 26th of January. And at the time also reported that symptoms had improved. Then fast forward all the way to February 18th, once again, dysuria, discharge symptoms, and presents to the outside clinic where the urine is sent for NAT testing. And once again, it's found that Mycoplasma genitalium is still present. And at the time, they said, well, let's send you to City Clinic on the 25th of February to get you evaluated. And when he presents to us, he again says that basically the same history, that he's been having the symptoms. And upon further questioning, we actually found out that he had reported no sex since December 8th. However, on December 8th, he did have an encounter. So presumably around the time of the 12/18 of 2024, he may have been reinfected. Who knows? We don't really have that information. However, he did mention that the one partner that at least that they disclosed was tested and found to be positive for Mycoplasma genitalium and was successfully treated with doxy-moxy treatment and had a negative test of cure thereafter. So based on all that story, we decide to do a urine NAT and send it for testing. And while we're waiting for that, we also decide, in conversation with the patient, to send it for resistance testing to the University of Alabama in coordination with them for both macrolide and fluoroquinolone susceptibility testing. Obviously, that's going to take some time. So in this moment, while you have the patient in front of you, what would you do while you wait for these results? Would you repeat doxy for 7 days, followed by moxy, 400 milligrams daily for 7 days, doxy for 7 days, followed by tinidazole 2 grams daily for 7 days, doxy for 7 days, followed by tinidazole 2 grams daily for 14 days, doxy 7 days, then minocycline 7 days, tinidazole 2 grams for 14 days? Or would you do one of these combos of persinomycins that you see here? Very interesting. So just for the sake of time, I'm going to move us along, but it seems like we're all sort of split up and not really reaching consensus necessarily on one particular answer, which it's sort of the point of this case in some ways. So the right answer here, and not really the right answer, but the decision that we decided to make, was to treat the patient with doxycycline for 7 days, followed by moxifloxacin 400 milligrams for 7 days. This was agreed upon based on the fact that this history from the 8th of December about this potential reinfection. And given that technically the patient didn't get the recommended treatment after that, which is doxy, moxy, we decided, well, maybe this is reinfection and we're not really dealing with resistance. So let's try it again and see what happens. And so based on that, we did that. And so let's move forward. Now, the resistance testing come back. And once again, it shows that this pathogen is macrolide resistant, but also shows a PAR-C and GYRA mutation, which correlates with moxifloxacin resistance or fluoroquinolone resistance in general. However, the patient also says his symptoms have improved slightly while on doxycycline, which that was within the seven days that he was taking doxycycline twice a day. So now, same question again. What now? Would you do anything differently? Would you continue the same thing? Let's give it a couple more seconds to see if we can get a couple more answers. All right, so we seem to be pretty even now with doxy followed by tinidazole for 14 days, or minocycline followed by tinidazole for 14 days. And they're not really the right answer, but again, what we decided to do is number 4, which is minocycline for 14 days followed by tinidazole 2 grams daily for 14 days. So the main point of this slide is really that there is really no real answer here. There are many routes that you can take for this. And this decision was actually made solely upon discussion with experts from University of Alabama, who basically say that in cases of resistant or potential resistance or persistent symptoms in the setting of mycoplasma, they will resort to doing either doxy or minocycline, and depending on the variation for 7 to 14 days, followed by tinidazole. And they sort of gave the caveat that there's a range that you can choose to do 7 to 14 days. However, there's really no data or evidence to suggest which one is better. Although in case reports, and at least anecdotally from some of the cases that they've treated, actually reported 2 cases in which patients actually improved after a 14-day course of tinidazole. So again, this is all sort of anecdotal. There's really no evidence. And so we decided to trial this out with our patient. Now, just a quick reminder of Mycoplasma genitalium. It is an intracellular organism that is quite difficult to culture, given that it takes months. And to my knowledge, at least, there's only 2 labs that are actually able to grow the organism. It can be passed via vaginal and anal sex, and although detected in the throat, it is unclear whether or not it can be transmitted via oral sex. And like other bacterial STIs, recurrent infections can occur and sometimes can be quite difficult to manage, at least in the setting of a sexual health clinic here at City Clinic. And it can be associated with an increased risk of HIV acquisition. Now, in the context of symptoms, for those individuals with male anatomy, it can both be symptomatic and asymptomatic. In the cases of non-gonococcal urethritis, for patients that present with symptoms of NGU, generally speaking, in the acute setting, it has been attributed to about 15 to 20% of those cases. And in individuals that have recurrent or persistent NGU, the prevalence of NGU being sort of the culprit is actually much higher, up to 40%. It is unclear, however, if it causes epididymitis, prostatitis, and infertility, and relevant at least to this case, which will provide some updates at the end. Now, pharyngeal colonization is possible, though it's really unknown whether or not it can cause symptoms in this area. And it is unclear if Mycoplasma genitalium alone is really sufficient to cause proctitis, although at City Clinic, we have seen many, many cases of proctitis in which the only sort of culprit or isolated pathogen has been Mycoplasma genitalium. And this is in some ways due to the validated labs that we have through the public health lab that we're able to send for this. Now, in individuals with female anatomy, again, it can be both symptomatic and asymptomatic, and it has been associated with 10 to 30% of cases of cervicitis and up to 1 in 5 cases of pelvic inflammatory disease. It has some possible associations also with miscarriages, as well as endometritis, preterm delivery, and infertility, and also consequences of symptomatic colonization are known for both sexes. So again, really unclear whether or not asymptomatic colonization really causes anything or whether or not we should be treating it at all. Now, in the context of who should we test, per the CDC, anyone with symptoms or signs of persistent recurrent urethritis and cervicitis who fail initial treatment, as well as people that are presenting with PID-like symptoms should be tested for Mycoplasma genitalium. There is an FDA-approved MGen NAT test for both vaginal and urine samples. And like I mentioned, through the PHL lab, we've validated a Mycoplasma genitalium NAT test for rectal swab samples. Now, any patient that's a known contact to patients with confirmed MGen should also be tested for Mycoplasma genitalium and only treated if positive. They also do not recommend to screen asymptomatic individuals. And I always like to sort of point out that at City Clinic, we test everyone for with urethral or cervicitis for Mycoplasma genitalium in the acute setting, rather than when they come back with recurrent symptoms or anything like that. And we have actually found quite a big number of individuals actually that test positive in the acute phase and are negative for gonorrhea, chlamydia, and other pathogens as well. As far as the epidemiology trends, there was a study that was conducted in 2023 that actually demonstrated that the prevalence of Mycoplasma genitalium across 6 major cities was around 16.6%, and urogenital specimens that were sent for testing for gonorrhea and chlamydia alone. And this was all across all the sexual health settings in the cities that are depicted here on the map. It was also noted that in these samples, MGen was actually found in patients that presented with symptoms of urethritis, vaginitis, cervicitis, as well as PID. And also in asymptomatic individuals, the prevalence of MGen was up to 9% in asymptomatic males and up to 15.4% in asymptomatic cis females. They also note, as you can see here on the map, that there was quite a high prevalence of macrolide resistance, as you can see on to your left, and also not as high, although a little bit lower in the context of fluoroquinolone resistance, but still rising as we speak. As far as the resistance mechanism patterns, for azithromycin resistance, this is actually correlated with a mutation in the 23S rRNA mutations. And for moxifloxacin resistance alone, it has been associated with the PAR-C and GYRA mutations. Interestingly enough, it's specifically for moxifloxacin, and it's unclear whether or not that sort of mutation crosses over to all fluoroquinolones altogether. And this will become relevant in terms of some of the alternative regimens that there are present for treatment or potential treatment. As far as treatment guidelines goes, first-line recommendations for anyone whose macrolide resistance is not available or unknown is generally doxycycline 100 milligrams BID for 7 days, followed by moxifloxacin 400 milligrams PO daily for 7 days. In any individual who tests positive for Mycoplasma genitalium and in which you have availability to macrolide resistance testing and is shown to be susceptible, you could alternatively use doxycycline for 7 days, followed by azithromycin 1 gram orally once, and then followed by 500 PO for 3 days for a total of 2.5 grams for the treatment. And individuals that are presenting with PID, in which the culprit is identified to be Mycoplasma genitalium and no other pathogens, then the treatment recommendation would be doxycycline PO BID for 7 days, followed by moxi for an extended course of 14 days. It's also important to also counsel patients that they should abstain from sexual activity for at least 14 days during treatment and until sex partners have been tested and completed therapy if found to be positive. And also important to note, because many patients would ask, that routine test of cure or rescreening if asymptomatic is not recommended. And if you are going to test again, say for instance for persistent symptoms, you should at least wait at least for 3 weeks post-treatment, given the high rates of false positives before you retest. Now, for some alternative considerations or special considerations, there is some data to suggest that these treatments could work. Starting with minocycline, which is an alternative regimen, generally is recommended to be used at 100 milligrams PO BID for 14 days. This has been shown to be effective in some case series, and it has demonstrated greater activity against Mycoplasma genitalium than doxycycline, with a 40 to 70% cure rate in comparison to doxy. Our recommendations at City Clinic is actually to go for minocycline in the absence of resistance data for individuals who failed initial first regimen. Now, pristinamycin 1 gram 4 times a day for 10 days has been licensed for use in France and also in North Africa for MRSA and it's been used in research in Australia and has shown some benefit, and actually it's demonstrated up to approximately 75% cure rates in some of the settings. Ciprofloxacin 100 milligrams BID for 7 to 14 days in combination with doxycycline is also licensed in Japan for use, and has demonstrated approximately 80% cure rates. And in the setting of moxifloxacin failure or known resistance, actually shown 69.5% cure rates for individuals who have opted to use that regimen for resistant Mycoplasma genitalium. Lefamulin, FDA approved for community-acquired pneumonia, however, no longer available, really, although it has shown 50 to 60% cure rate in one small study. Other alternative regimens, which is one of the most popular ones that people opted for, is tinidazole 2 grams PO daily for 7 to 14 days. Again, this is all based on case reports and expert opinion. There's really no data to really drive the duration for tinidazole at this time, although, again, anecdotally, 14 days seems to be better than 7 days in the settings that it has been used. And in terms of like why this works, no one really knows, but there's been some data in a randomized controlled trials in women with PID in which women were either randomized to metronidazole, ceftriaxone, and doxy compared to just a standard arm, which was ceftriaxone and doxy. And it actually showed that there was a significant reduction in Mycoplasma genitalium detection from cervical samples at 30-day follow-up, with a dramatic decrease of 4.4% reduction versus 14.1%. And this was proven to be statistically significant. Now, suliflodacin, which I always struggle pronouncing, has shown in vitro activity against Mycoplasma genitalium, but there's really no data on its clinical efficacy to date at this time. Now, when treatment fails, I think it's always important to put a plug that this should actually be reported to the CDC and SFDPH. As we know, resistance is rising. And so from the public health perspective, it is important for both the CDC and SFDPH to know about these cases in order to not only investigate and contact trace partners, but also to just follow up in the emergence of potential resistance as well. As far as partner management goes, partner testing can be offered for patients with a confirmed Mycoplasma genitalium, and like as mentioned before, only treating patients who are actually found to be positive, even if asymptomatic after a known contact. Now, there are a few reasons why treatment is only offered to those who are test positive to a known contact to Mycoplasma genitalium. Number one is that concordance between partners is actually much lower than for chlamydia. As you can see here, in chlamydia can be up to 75%, and for Mycoplasma genitalium it's only 30 to 40%. Number two is also the length of treatment, which can be 2 weeks of antibiotics. And as we know, you can have serious side effects from some of these antibiotics, specifically speaking to moxie with tendonitis and tendon rupture. We have seen some cases of tendonitis in the clinic as well. And I know at least of one tendon rupture, not that I have seen, but at least that someone has mentioned to me from the clinic. And so that's also something concerning. But I think most importantly is also the high level of resistance and that we know that it continues to rise. And so we're exhausting our antibiotics already. And that's another potential reason as to why not treating partners who are not having symptoms basically and are also testing negative, or at least waiting for the test. And then treatment also may reduce symptomatic reinfection of patients, though there's really no studies to suggest this, but it is thought to be that if someone is asymptomatic, test positive, and you treat them, when they do become reinfected, they may have less symptoms. But again, this is all, again, skeptical and not really proven necessarily. So I think the take-home points here is that MGen is an emergent STI with high resistance rate. Really, diagnosis relies on NAT testing. And when not available, it's really hard to really manage, but if it is available, it also doesn't seem to be that helpful because we really don't have that many options really. And limited options really make this rather difficult. I think I want to provide a little update about this patient that I actually just learned about yesterday, which is patient actually followed up with one of our clinicians and actually mentioned that symptoms actually have not improved, even though they have been on this, and actually also reporting some testicular pain, which now makes us think, are we dealing with epididymitis here? Which again, it's unclear whether or not this is really related to or not. And so we're also bouncing off ideas of what to do next. Where do we go from here? In consultation with some of our colleagues, we've also learned of some patients who have had some telehealth visits with, I think, doctors from the Netherlands or France, and then they are flying to France to go and pick up antibiotics. Or we've also learned of people just like going to for different routes to be able to get this for compassionate use and things like that. And so again, it's an evolving case, which in many ways is exciting, but also kind of scary to think that it's happening. And so, yeah, thank you.
Thank you so much, Franco. Yeah, that case is really a challenging one, and I think we're seeing more and more of these cases with treatment failure, MGen with treatment failure, and they're hard to manage. And there's emerging, expertise on this, but limited data to guide us. And so do reach out, if you see these cases. We have been talking with, like Franco said, our colleagues at the state, with Ina Park, Kelly Johnson, with our colleagues at UAB. And I think now there's a consideration, Oliver, of treating the patient with omadacycline. I don't know if Oliver's been very involved too, so I'll give you a second to chime in.
So he had symptoms that were very concerning for yeah. Yep. Okay, here we go. Oh, so right. So he had symptoms that were concerning for epididymitis and even possibly an epididymal abscess. He got a testicular ultrasound, which was normal except for some benign looking cysts and a reactive lymph node in the right inguinal area. He saw a urologist who was very reassuring. He's still having this intermittent testicular pain. He'll finish week 2 of tinidazole on Friday. What we're planning to do next is try omadacycline. Kelly Johnson's been really helpful in this regard, as well as Kathy Yang, the PharmD over at Parnassus in terms of dosing. And while that's cooking, we're actually pursuing how to get him pristinamycin. You can't get pristinamycin in the United States. There was one case in which someone got it for compassionate use because the patient was very immunocompromised. So Jason Zucker at Columbia has had some success in connecting patients by telemedicine with a STI clinic in Paris, and then having the patient go get pristinamycin. It's insane. And we've not pursued going to Japan to get citalfloxacin yet, but that's where we are with this guy.
Thanks, Oliver, and thanks, Franco. So we have one last case for you. Kind of sticking with the theme you're hearing here about resistant pathogens in the field of sexual health. So this is a 55-year-old HIV negative MSM on PrEP who comes in with 2 weeks of a rash that involves the penis, the suprapubic area, and the lower abdomen. The rash is uncomfortable and mildly itchy. He has no history of syphilis. He's not on doxypep. He has no recent travel, and he's sexually active with 4 partners in the past 3 months. So you can see here on the penis, there's sort of a circumferential plaque with some overlying scale, and then maybe a satellite lesion below. And then in the suprapubic area in the lower abdomen, there's some additional patches and maybe a few papules there in the inguinal folds. So what is your leading clinical diagnosis here? Do you think this could be secondary syphilis, psoriasis, eczema, tinea, nummular dermatitis, or mpox? See if anyone decides to vote for anything else. Okay, everyone thinks it's tinea. Well, so does the provider. And so he started on topical clotrimazole, but the rash persists and spreads. And so you consult derm. And this turns out to be yet another emerging sexually transmitted pathogen, trichophyton metagrophytes 7 or TM7. And there's a recent literature emerging on this pathogen and on this phenomenon more broadly of tinea genitalis, right? So we think of tinea corporis, tinea cruris, tinea capitum. There's even tenital gladiatorium, which is like ringworm and tinea infections in wrestlers. But this is a bit of a newly coined term, which is tinea infections involving the genitalia. And you see here a smattering of some of the published literature. From 2014, there was a case series of 7 people in Thailand, 5 were men and 2 were women. And then in France in 2022, there was a cluster of 13 cases of MSM. And this really started the conversation around, is this spreading particularly within sexual networks of MSM? And then in 2024, again, Jason Zucker, who's been involved in MPOX work, and MGen, who Oliver just mentioned, led this MMWR describing 4 cases in MSM in New York with TM7. And some of the features of this that are concerning are not only that it could be spreading through networks, but the presentation of TM7 tends to be more inflammatory and more severe than regular ringworm or tinea crurus. There have been multiple body sites affected, particularly the genitals, but also the face. And this particular species of trichophyton is resistant, can be resistant to topical azoles. Fortunately, most of these cases have responded to oral terbinafine. There are other emerging antifungal resistant trichophyton, however, that are resistant to oral terbinafine. For instance, one you may have heard of called trichophyton indotinei. Itraconazole has also been used to treat some of these cases, and some have needed prednisone to manage severe inflammatory reactions. So again, this phenomenon of tinea genitalis is emerging. In June 2024, we released a health advisory for providers to let folks know about this and to be on the lookout for it. If you do see a patient in whom you suspect tinea genitalis, it's particularly if it's not responding to topical therapy or oral therapy, please try to obtain a fungal culture. And if it does turn out to be a trichophyton species, TM7, T. indotinei, other emerging antifungal resistant species, then there are several reference labs that can do whole genome sequencing as well as antifungal susceptibility testing. Again, this is an emerging phenomenon. So from a public health standpoint, we're at the stage of trying to gather data and learn. So please do report these to us. We are tracking them locally and at the state, and as the mycology group at CDC is also monitoring. So I thought I had a couple other pictures, but I don't. Okay, so to summarize from the cases you heard about today, just a reminder to screen all sexually active people, regardless of gender or sexual orientation, for syphilis at least once and more frequently based on risk of exposure. If you have a high suspicion for syphilis, test and a low threshold to empirically treat. We are definitely not out of the woods with mpox. This is probably going to be, an STI that it's not going to be eradicated. So keep it on your differential when you're seeing patients with genital lesions. Remember, they tend to be painful and circumferential and indurated, but there's range of presentations. Resistant MGen is out there and there is no consensus yet and not a lot of data to guide us on how to manage it. And obtain a fungal culture if you're suspecting resistant tinea. So thanks everyone. I think we have a little time for questions.
Thank you so much. That was fantastic. We'll start with the audience. Any questions? Or we have a few online. We can start online.
Yeah. Fantastic talk, both of you. One from online with regards to resistant MGen is, do you combine tinidazole with doxy for MGen? And if yes, is doxy prescribed for only 2 weeks or is it a month?
You combine it, right? I believe that yes, and I believe the length of therapy is again, nobody knows, 7 to 14 days is like the range. But usually people tend to opt for longer. But again, there's no really guiding evidence to that. I don't know if you have anything else to add, Oliver.
Yeah. So there's no
Sorry.
standard way around. So the reason, so doxy and minocycline, but doxy in particular has a really interesting role in MGen therapy. By itself, it'll cure about 40% of infections, but that is not really acceptable. What it does do is it reduces the bacterial load. A week of doxy will reduce the bacterial load so that the second antibiotic, whatever it is, has a much higher success rate. And that also seems to limit the acquisition of resistance mutants in the strain. So I think at the bare minimum, and I'm speaking as an N of 1, a week of doxycycline, I would give anyone who is getting treated for MGen, followed by another antibiotic. You know, most of the time moxifloxacin will work just fine, but as Franco has shown in this case, there is resistance nationwide, and this is really the first case that we've seen at City Clinic with it.
And one just comment about the doxycycline part that I think is so fascinating is that doxy doesn't work, but not due to resistance. It's not resistant. It just is not very good.
Yeah.
So it's not like there's a ton of resistance. So that's interesting.
And this guy, every time he got treated with doxy,
He felt better.
Yeah. And then they came back. And
Yeah.
you see this in the literature about MGen treatment. Like resistant MGen seems to present as temporary resolution and then relapse.
Yeah. Yeah. And Franco asked me, and many others have asked, like, well, does doxypep, is that going to make things better, worse, or the same for MGen? And the answer is we don't know. There's some data from the French study suggesting that MGen went down. We're still analyzing our data. It is tricky to sort out. But there is, in theory, it might make things better. And that's the trend and direction we're seeing things, but we have to sort it out. But my question to the group is a very mundane one. Can we send fungal cultures? Like if we're going to send a fungal culture for tinea, like how do we do that? Can we send that to Clin Labs? Is that special? I don't know how to do it.
I think you can, but I'm not sure the collection kit. I know that in other clinical systems, patients have, and actually Oliver, we've now brought on the ability to do this and Franco at City Clinic. Yeah. Do you want to speak to that? So that if you can't do it where you're practicing, you can send your patient to City Clinic, but you can say more.
Yeah, I mean, the only thing that I'll say, I personally have not collected it, but I know in our lab, we do have everything that we need in order to do so. And so if anyone is wondering like what you would need, I'm happy to put you in touch with Jonathan Carlson in our lab, who has pretty much like developed the protocol for us to collect it if we ever suspected it as well. So yeah.
I'll elevate what Jorge just said. Is like Durham is certainly doing it. I don't know if anyone has insight or seen them do it here, but there must be a way. Yeah. Any other? I can ask another question from in person, which is great. Or sorry, from online. You mentioned the possibility of monoclonal antibodies for Mpox. Are these available through a study?
Not at this time.
Yeah. Okay, not yet. Any other questions from the audience?
Yeah, so brincidofovir, like tecovirimat, is available through an investigational new drug protocol through an IND. Also not necessarily easy to get, but doable. So I think we have used Brin at least a couple times during the outbreak. Okay.
We got it. You guys got it too.
Yeah, yes.
You can get it.
Excellent. And then last question from online, where someone's asking for case 1, is there a reason why urine GCCT testing was not indicated? Do you mind expanding on that?
Yeah, that's great. Thanks so much for that question, because I realized I didn't actually address that. I'll try to flip back to the side, but essentially there are not any recommendations to do asymptomatic screening for urine GCCT in MSWs, and men who have sex with women only. Wow, this slide is way back. So yeah, so here are citywide STI screening guidelines, which are available on the SF City Clinic website. So it is recommended to screen women 25 and under for urine GCCT annually, sexually active women, even if they're asymptomatic, but there is no such recommendation for young men, actually. And our patient is 36, so it's outside of the guidelines. If they have symptoms, definitely test them. There are settings where young men are tested if they live in a high prevalence community upon entry into jail or incarceration settings. So there are some limited places where we do asymptomatic screening of MSWs, but essentially there's just not data to support that it's a cost-effective public health approach.
Fantastic. And then last comment, I'll say to go back to our conversation about Mpox therapeutics, Kelly Johnson's adding in the chat here that vaccinia immunoglobulin is available through the CDC in addition to the conversation you had discussed around Bryn.
Great. Yeah,
Yeah.
thanks, Kelly.
Thank you both for a fantastic